Hi everyone, this is Beth and we are going to be starting this voiceover lecture on pharmacological treatments in schizophrenia and schizophrenia spectrum disorders. Before we get started though, I just want to make sure you're aware that I am drawing this information from chapter 4 in your book, which is pharmacology, and then also chapter 23, which is the schizophrenia spectrum disorder chapter. But I've organized this outline. It doesn't follow exactly from your book, but I'm taking information from both chapters and organizing it in what I think is the clearest way to study this study these meds and to understand these medications. I will be pointing out page numbers as we go along. All right, so medications that we're using with schizophrenia and the other disorders generally are going to be the antipsychotic medications. And I have down there page 70 and 77 in your book to get us started. But these medications are broken into two groups: typical antipsychotics and atypical antipsychotics. And it's going to be very important for you to know the difference between those two, because there's some very significant differences. So these are some things that we'll just have to basically memorize as far as the differences between them and what's unique to each of those groups. Just a little bit of history with the antipsychotics. It wasn't until about the 1950s when the first antipsychotic came about. And when that antipsychotic came out and we discovered that it could help many patients, especially with positive symptoms, that was a wonderful breakthrough for psychiatry at that time, because many of the patients who were maybe committed to institutions or who were living in institutions, there was no treatment for those hallucinations, no treatments for those delusions, or no medication treatment, but they were given many different types of psychosocial interventions to try to help them with that. But once these antipsychotics came out, we were able to find out that we really could give a lot more freedom to these people as far as freedom from their positive symptoms. And then as we progress, and I'll give you some little history when we get to the atypicals as well. Now on your outline there, you can see that I have listed some typical antipsychotics, and you may or may not have heard these. You probably have heard of Haldol or haloperidol. That's probably the most frequent one that's used most frequently now. We really don't see Thorazine or Perlixin or Navaine given too much anymore, although many times it will depend on the doctor and depend on the hospital that the person is being treated in. Now for me, I'm going to continue to in exams tell you that these are typical antipsychotics. Okay, but like HESI and boards, they are not necessarily going to do that. So make sure that you're aware of that, and you're going to have to recognize which are typicals and which are atypicals. Atypicals. Okay, so and then just another point that I want to make is that these medications, whether they're typicals or atypicals, they do not provide a cure. Okay, unfortunately, the only thing that we can do with these medications right now is to manage the signs and symptoms. Okay, so let's look a little bit more at typical antipsychotics. The action here is very important, that they block the dopamine receptors in the postsynaptic cell. And when you're thinking about this, really think back to the biochemical theory of schizophrenia, or the dopamine hypothesis. And what did the dopamine hypothesis say? Right, that these positive symptoms were due to excess of dopamine. Okay, now with the action of these typical antipsychotics, we're blocking the receptors, and this is going to decrease the amount of dopamine in the brain, which is going to decrease the psychotic symptoms, or we could say that they're targeting the positive symptoms of schizophrenia. So this is where, again, it's very important for you to be able to quickly know what are the positive symptoms, be able to list those off, and what are the negative symptoms of schizophrenia, and list those off as well. Okay, so just one more time, the typical antipsychotics, they target the positive symptoms in schizophrenia. Side effects of the typical antipsychotics. Your set to the table 4 and listing many of those side effects, and then also the nursing interventions for the side effects. And that is what I would like you to know as I'm going through these side effects. I want you also to be thinking about what are the nursing interventions for these side effects. Okay, so let's start with the first one, anticholinergic side effects. You should know these anticholinergic side effects, but I will review them. Dry mouth, intraocular pressure, blurred vision, tachycardia, urinary retention, constipation. So we have these side effects that the individual has to deal with. Now, when we talk about what are the nursing for the anticholinergic side effects, you can see in that table that, instructing the client about how other anticholinergics in combination can increase all of these side effects. If a person has dry mouth, hard candy, sips of water. Most of the places that I worked, every time a meal cart came up, they also brought up a little bowl of hard candy that was sugar-free that we could sit at the nurse's station, so that if a person was having dry mouth, they could hard candy. Talk to the patient or clients about good oral hygiene, and to really try to let us know if they're having any urinary retention, if they're feeling having any signs of constipation. And you should know all the nursing interventions for constipation. You could probably list those off for me now. Eating, a diet that's has bulk in it, or a lot of roughage, lots of activity, drinking lots of water. All of that's going to help with the constipation. As far as urinary retention, this is something depending on your client. If your client is having a lot of difficulty with disorganized thoughts, they may not be able to tell you about if they're feeling like they have urinary retention. So it is very important for us as nurses to be aware of when our patients are, as much as possible, are they urinating, and are they having bowel movements? Because if we fail to assess this, our clients could get into some trouble. And I recall one client who nobody was really paying too much attention about how often she was going to the bathroom, but finally somebody noticed that her abdomen was a little bit distended, and we looked a little bit closer, and she palpated her bladder, and it was very full, but we had to get a catheter to take that urine off because she was not able to void, and we took a great deal of urine off of that bladder, and that has its own problems with that. So we need to be assessing all of those physical things as well. Okay, let's move on then to the adrenergic, and please, if your notes don't have this, put in adrenergic blocking side effects. So adrenergic blocking side effects block the secretion of epinephrine and norepinephrine that's going to the sympathetic nervous system, and therefore that's going to cause vasodilation, possible decreased cardiac output. So some side effects that would fall under this category: hypotension, orthostatic hypotension, dizziness, fainting, EEG changes. So again, very important that we are making sure that we're doing vital signs, making sure that we are doing orthostatic blood pressures. And if you don't remember how to take an orthostatic blood pressure, make sure you know how to do that. Many times we don't do all the lying, sitting, and standing, but usually lying or standing or sitting and standing, and seeing if there is a significant difference in that postural change. And you know that if a person does have that hypotension or orthostatic hypotension, that it's very important that we, again, put into place nurse interventions. And you know what those are. Instructing the client to rise slowly from a sitting to standing position, doing those orthostatic blood pressures. And if they do have that, again, making sure that they're drinking lots of fluids. If they need to be on a fall risk, make sure that they are on a fall risk. The next group of symptoms, extrapyramidal side effects. Sometimes we abbreviate these as EPSE. It starts talking about that on the end of that page. And I'm going to be going over these. The first one that I have listed here is acute dystonic reaction. Some people will just call this a dystonic reaction. This is when a person has bizarre, uncoordinated movements, usually in their head and neck, and will cause the head to contract and turn to the side. The patient may also complain of having a stiff neck. Also, the eyes can have an oculogyric crisis, and that's where the eyes start to roll back into the head. If this continues, the worst case scenario that could happen is that just these contractions of the neck, the head, shoulders. We can have other contractions, and the worst thing that could happen would be a laryngeospasm, where the larynx starts to spasm. And what do you think that could cause? Why is that something that we're very concerned about? Okay, right. It's possible for that airway to close up. And if that airway closes up, then that becomes a very acute emergency, and that's why it's called acute dystonic reaction. It comes on very quickly, and it can quickly progress into a life-threatening situation if that airway is closed. So the treatment here, or the biggest nursing intervention here, is to treat with IV Benadryl, which is just going to produce muscle relaxation on all those areas, and to prevent or to treat that laryngeospasm. Some people will say that they can also give IV benzotropine or cogentin. So that is the main nursing intervention with acute dystonic reaction. In class on Tuesday, I will be showing some videos that will show you what acute dystonic reaction looks like. But I remember when I first was working at University of Iowa, I was passing medications, and a young gentleman, he was probably 21, 22, came up for his medications, and I was passing them to those. He had been on an antipsychotic, and I can't remember, a typical antipsychotic, for the past couple of days. But as I was talking with him and getting his medications ready, I noticed his eyes were kind of looking up at the ceiling, and he was kind of looking up, and I knew it didn't I could tell the difference. It wasn't like he was listening to voices, but his eyes were just kind of rolling up to and I thought he was looking up at the ceiling. And then he would come down and make eye contact with me. I thought, that's kind of weird. I wonder what's going on with that. But he did that a couple times, and I, just being a new nurse, did not really recognize that as kind of the beginning of an oculogyric crisis. But after I gave him his medication, he was walking down the hallway, and I was busy with something else. But then all of a sudden I heard a couple of nurses and a resident saying, "Quick, we need some help over here." But he had, as he was walking, he had a severe gyrate crisis. His eyes really rolled back and his neck was starting to contract, and he fell down in the hallway. And of course the more experienced nurses and the residents recognized that immediately, and his head was turned to the side as an acute dystonic reaction, and they quickly gave him some IV Benadryl, and then in about 20 or 30 minutes that resolved. So I'll never forget that, but we'll see a picture, see a video of that in class. Okay, the next extrapyramidal side effect is the Parkinsonian syndrome, and some people will call this pseudo Parkinson's. And I don't know if you guys have studied Parkinson's disease or not, but if you want to look that up or Google that real quick, you'll see what I'm talking about with a Parkinsonian syndrome. These individuals have muscle rigidity and muscle stiffness. You also may see a tremor in their hands. They oftentimes have a shuffling gait and may have drooling. Might have loss of muscle movement. Many times they also have like a mask-like face that's very common in Parkinson's disease. Also with this syndrome, as you notice them walking, many of them will lack, if they're having this side effect, will lack an arm swing. If you or I are walking, our arms swing naturally, by our side. But these people with a shuffling gait really don't move their arms at all. They don't have a natural arm swing. There can also be cogwheeling as part of this Parkinsonian syndrome, and cogwheeling is just where if you know what a cogwheel is, like gears, say in a clock, or that's all how I can describe it, but gears. But if you would put your thumb and your forefinger on the side of your elbow, if you did that just normally to yourself, you would feel that it's nice and smooth. But a person who's having cogwheeling, you'll have kind of a start, stop feeling, and that would be cogwheeling. And that muscle rigidity, cogwheeling in the joints, or stiffness in the joints as well. And the treatment for Parkinsonian syndrome is going to be benzotropine, which is spelled BENZOTROPINE, or the trade name is Cogentin. And this is an anti-Parkinsonian agent, and it helps with those muscle spasms, stiffness, tremors, drooling. So that's the treatment of choice that we would give. Sometimes if we are don't want this to start, or the doctors may use the benzotropine as a prophylactic, so to actually prevent it before it actually starts. So you may see that as well. And we'll see a video of that also. Akathisia is the next side effect, and that is motor restlessness. And that is the person's inability to sit still. Many times you'll see them pacing in the hallways. You may see them sitting in a chair and just rocking back and forth, maybe tapping their foot tapping their foot on the floor, or just shaking their foot if their legs are crossed, wringing their hands, again, wrestling around in their seat. And they just say that it's, describe it as this inner restlessness. Many times it can be misdiagnosed as anxiety. Or, we talked about the other day about agitation and aggression. Sometimes it could be misdiagnosed or misinterpreted also as a person starting to get agitated. That's why it is so important that when we start to see this pacing, this restlessness, is that we go and assess it further. Start to ask the patient clients what are they feeling, what's going on. Tardive dyskinesia is the last one on here, and this is involuntary rhythmic movements, usually of the face, lips, and tongue. And this is a potentially irreversible side effect. Even when the medication is stopped, it can continue. We don't see tardive dyskinesia very often here in the 2000s. It used to be before 2000 we would see it somewhat frequently, but because we have moved to the atypical antipsychotics, We really don't see it all that often, but we can. But that's not to say that we won't see it. They just within this last year they have come out with a medication, and I have it written down on the PowerPoint or on the lecture voiceover, is a medication called valpenzazine or Ingrezia. I'm not sure how to pronounce that. It's so new, but that they believe that is may help with tardive dyskinesia, and they're starting to market it, and studies have shown a degree of successfulness. So that medication is very new. I'm not going to quiz you on that medication. But one thing, I have the AIM scale written down there as well. That AIM scale is very important to do with people that are started on typical antipsychotics, because the AIM scales goes through and looks at muscle twitching, muscle tremors, and we really are trying to detect any type of tardive dyskinesia at the very, very beginning stages, so that we can either discontinue the medication or possibly treat it with this new medication. But usually besides this new medication, the only treatment really is to stop the medication and go from there, in hopes that it will go away. But if they've been having tardive dyskinesia for a very long period of time and you take them off the medication, they will continue with that tardive dyskinesia. Okay. And you see at the very end of that, I have the treatment for EPSE, and so I basically have told you the medication treatments for EPSE as I've been going along. With acute dystonic reaction, we said IV Benadryl or possibly IV benzotropine. Parkinsonian syndrome also would be benzotropine, usually PO. It would not be severe enough that we would necessarily give that IV. It usually starts slowly and progresses. Akathisia, we could also give benzotropine PO. And tardive dyskinesia, I just talked about that, stopping the medication as soon as we start to discover that there's some muscle tremors or muscle twitching in the face or the neck or the body. Okay. The next side effects that we see here are side effects of the blood, skin, and eye. Individuals who are on typical antipsychotics may experience hives or rashes. Okay, they also may complain of blurred vision, dried eyes, and usually, artificial tears may help with that. Many times, if the blurred vision may resolve after a week or two of medication, or a week or two after being on the medication. Of course, if a person is having hives or rashes, we would want to hold that medication and contact the doctor. Another side effect is photosensitivity, which can lead to an increased risk for sunburn. So we want to make sure that they are instructed on wearing a lot of sunscreen, long sleeves, staying, all those things about sunburn, staying out of the sun from 10 to 2, maybe wearing a hat, sunglasses. And I'll talk a little bit about blood in a little more in a little bit. Weight gain is another side effect. Because it can stimulate the appetite, weight gain is a significant side effect, because as you can imagine, nobody wants to be on a medication that causes you to gain weight. The next one, neuroleptic malignant syndrome, which is abbreviated NMS, is a potentially fatal side effect, so something that we need to be very always be assessing for. Men are more likely to get neuroleptic malignant syndrome, and younger clients as well. Now, not always, but usually we see neuroleptic malignant syndrome starting around 72 hours after it's first started, and maybe more, a couple of months or that sort of thing, but that's kind of a range. Signs and symptoms include severe EPS, which we just talked about, that EPSE. We can have beginning of muscle breakdown, which we might see with having an increased creatinine kinase. We can also see fever, tachycardia, an increased blood pressure or a labile blood pressure. We can also see diaphoresis, an alteration in consciousness, such as, starting to become disoriented, may even progress to, being very, very disoriented, slurred speech, and increased muscle rigidity. Now, when neuroleptic malignant syndrome begins, they develop, like I said, one of the big kind of clues is a high fever or beginning of a fever. And so whenever somebody has a fever, we cannot discount that and say, oh, it's a flu or just as, something random. But we need to be thinking worst case scenario, this could be neuroleptic malignant syndrome, and let's begin assessing it even further. Now, because of the muscle breakdown, the person, if that starts to continue to build up, could eventually have renal failure and could actually die from this syndrome. So we would obviously hold the medication, not administer it anymore, contact the doctor immediately, and they will then start to treat the symptoms. The next medication that I have down there is the next side effect is CNS effects or central nervous system effects. This would be like the possibility of having seizures. Sedation is a very real central nervous system effect, especially certain medications will cause more sedation, and we need to be really aware of this. Sometimes we want sedation, especially if the patient is very agitated or violent. We might actually give more than we would for a regular treatment just because we want that side effect of sedation to calm the patient down, to help him to sleep, maybe to decrease agitation and violence. But if the person doesn't have agitation, isn't violent, we really do not like, obviously we don't like, and the client doesn't like having this feeling of sedation. This is where sometimes you feel like, sometimes the clients will say, oh, I'm so tired, I just feel like I'm kind of dead to the world all the time, I'm tired, or I just feel kind of like a zombie, I'm feel so tired all the time. And so, again, we want to report all of these different side effects and make sure we're being very aware of them. Hormonal side effects. With men, a person can, and I don't have number 8 on your outline, so you should add this, number 8, hormonal effects. Increased levels of prolactin, which can cause gynecomastia and galactorrhea. So just be aware of that. And if a patient is having that side effect, we would want to, again, lower the dose, but also, and it may be that we need to try another type of antipsychotic. With women, we can have amenorrhea, so that's another hormonal effect. So I think I've covered all of the side effects for the typical antipsychotics. Now, how would you feel if after looking at all of these different side effects, how would you feel if the doctor said you had to go on this medication, or one of your family members had to go on this medication? That's a lot of side effects to possibly have to deal with. So just to kind of be aware that when the patients take this medication, agree to take this medication, they're also taking into the possibility of having all of these, and that's not really something to look forward to. So we need to be sensitive to that and have empathy and make sure that we're really educating them on all of these side effects so they can be aware of it and hopefully report to us if they're having side effects, but that we can also be assessing very closely for all of these, because some of these side effects are pretty severe. Now, just another note is that if a person has started on these typical antipsychotics, it doesn't mean that they're automatically going to have all of these side effects. No, everybody's going to be a little bit different. There might be a person who is, and every typical antipsychotic might cause different side effects for different people. So we can't necessarily predict which ones one person is going to have or what they're not going to have or how severe they are. But we have to educate them on all these side effects and then make sure that we're assessing for all of these side effects. Okay, now let's talk about the atypical or newer antipsychotics. Some people will also call these second generation antipsychotics. Now, these atypical antipsychotics work on both positive symptoms and negative symptoms. So that's a very important distinction. And generally, they are going to have less side effects than the typicals. It is possible for them to have, for a person on atypicals to have all the same side effects that we talked about with the typicals, but if they do, they're going to be less severe. Okay? Now the action here is they block the dopamine receptors, so that's the same as with the typicals, right? And therefore they're going to work on positive symptoms, but they also are going to block the reuptake of serotonin in the presynaptic cell. So that basically they're enhancing the effectiveness of serotonin. And we know that serotonin, if we increase serotonin, that can have can help a person with depression and have some mood stabilizing effects. And that is where the serotonin can work and work on the negative symptoms. Okay, so the serotonin can have a mood stabilizing quality and can help with possibly giving a person a little bit more motivation, maybe decreasing some of their anhedonia, giving them a little bit more energy. So you can see where these atypicals can work on both positive and negative symptoms. Now, these newer antipsychotics or atypicals, the first one, which is clozapine, it did not come out until about the 1990s. So there was a long period of time where we didn't have these atypicals. But now we do, and like I said before, they work on both positive and negative symptoms, which the fact that it can work on negative symptoms was kind of a breakthrough, because before we had just medication that worked on the positive symptoms, and that was all great and good. We got rid of those psychotic symptoms, but the person was still left with some severe debilitating negative symptoms. But now we have this medication, or these atypicals, and we're able to relieve some of those negative symptoms as well. So it was really kind of a revolution, if you will, and really great for our clients that we now have a medication to work on both sets of symptoms. So that was very, very a great breakthrough. Okay, so let's talk about side effects. Now, I said that if a person on atypical, they possibly could have all those side effects that we just talked about with the typicals, but they would have them in a less severe form. Okay, so that's a very good positive thing about these atypicals. The side effects are generally going to be less severe. And then after we've had these atypicals for a period of time and have done studies on them, the only big concern now is that we are seeing in studies that people are developing hyperlipidemia, or increased cholesterol, and diabetes. And sometimes you'll see this being referred to as metabolic syndrome. So these are very, significant side effects, because it's not what we want is to give somebody a medication to help with their positive and negative symptoms, but yet now we are inducing, if you will, or causing the possibility of having this metabolic syndrome. So it's again, we're not super happy with this, but these are some of the side effects that may develop in some people. And so then we have to be aware of that and assess for that, and then also to manage that as well. Examples of atypical antipsychotics, I have quite a few listed down here for you. The one big one that I want a big star by for you guys is clozapine or Clozaril. And I think I have clozapine. I do have clozapine spelled incorrectly, so you can correct that. On your outline, it's correct. One of the big side effects here for Clozaril or clozapine is agranulocytosis. And you guys probably know what agranulocytosis is, but that's a decrease in WBCs. And because of this, okay, and what happens when we have a decreased white blood cell? The person is more prone to infection, right? And if he does get an infection, he's not going to be able to fight it because he doesn't have the WBCs, and that can be very, very severe, significant, and possibly a fatal side effect. So because of this, Clozaril is usually used as a very last resort. Used as a last resort when these other atypicals may have been tried and don't work, or maybe some of the typicals have also been tried and don't work. Okay, because we don't take this lightly at all. So like I said, used as a last choice if they can't tolerate some of the prior side effects. Maybe they're having severe EPS on the other medications, or like I said, maybe they're treatment resistant, they're not responding to any of the other medications. So because of this possibility of agranulocytosis, or that decrease in WBCs, we need to monitor, if a person is on this medication, we need to monitor the white blood cells weekly for the first 6 months, and then bi-weekly. So weekly for the first 6 months, and then bi-weekly. That's very important, and we're doing this every week. So again, you can tell that when they first start on this medication, we are very concerned about this white blood cell count, and we're going to be assessing it. Now, normal white blood cells, you guys probably remember 4,500 to 10,000 would be the normal. If somebody, and so we're watching that very closely, if somebody dips below 3,000, that is something, you know, that we're very, very, very concerned about. But if they go below that 4,500, it may be that we watch that for a little bit, but then probably will take them off of this medication as well. And then you can see the other examples that I have on your outline for newer or atypical antipsychotics. The last thing that I want to talk about on this outline, or on this voiceover, is the depot injections. Okay, or they can also are referred to as decanoate shots. These are IM intramuscular shots that are long-acting. Many times they can, and again, you can have depot injections with Prolixin or Haldol or Geodon, Risperidol, and each one of them will last for different periods of time, but generally they're going to be lasting from 3 to 4 weeks. So the person only has to take this antipsychotic in an IM form every 3 to 4 weeks. Okay, and again, it kind of depends on what medication is, but that's the general, how long acting. Now, what is the advantage of this? Why would we decide to do depot injections instead of PO medication? Okay, you can kind of think about that a little bit. There's a lot of advantages to this. One of the advantages is that if a person has difficulty with remembering medications, if they're supposed to be taking medications 2 or 3 times a day, you guys know, even if you're supposed to take something for 2 or 3 times a day, sometimes you forget, right? You get busy with life, and sometimes you forget that. And if a person is forgetting a dose here, a dose there, with these antipsychotics, that may be pretty significant. So a depot injection can be very helpful in that way, or there's an advantage to that. They wouldn't have to come into the doctor or for medication. You know, they'd come into the clinic every 3 to 4 weeks and get their shot, and then they'd be okay to go until the next 3 or 4 weeks. So they are long acting. Another thing it can do is it can decrease the ambivalence or the indifference about taking medications. Every time possibly a person with schizophrenia is taking their medications, you know, another day, they might start to have, you know, varying thoughts of, do I really want to take this? Do I not want to take this? Is this good for me? Is it not good for me? So it decreases ambivalence as well. You take it once a month, and they're set with that. Also, we may have patients that are have an outpatient commitment. That means that the court has said, yes, you can leave the hospital, but we're going to put stipulations on your outpatient. And many times one of the stipulations is that you have to come in to the clinic for depot injections. Okay, and just the last thing with that is that these medications are given deep IM and in a Z-track method. And you guys remember, or should remember, what a Z-track method is. It hopefully reduces pain, but it also can prevent the dispersion of medication into the subcutaneous tissue. And so that's why we give it in that manner. All right, so that's all that I have for this voiceover. I want you to bring any questions that you have to class on Tuesday, and we'll review that. Thank you.